that means our economies are failing. If climate and health challenges continue to rise, it means our economies are failing. If women continue to lack access to resources and do not get recognition also for their unpaid work, our economies are failing. We need to measure differently. We need to move beyond the measurement of GDP to express how we're reaching the goals of health and well-being, of an economy that sets new priorities. And as you will hear today, countries have moved forward on this agenda. You, of course, will also be discussing a resolution on health and the economy, and WHO stands ready to take this agenda forward. We have a wonderful panel here this afternoon, and we have a number of very distinguished speakers from the floor. And it is my great pleasure to guide you through this session. My name is Ilona Kickbush. I'm the founder and chair of the Global Health Center at the Graduate Institute for International and Development Studies here in Geneva. It is my great pleasure now to first give the floor to our wonderful Director General, Dr. Tedros, who took the giant step to establish the Council on the Economics of Health for All, and as many of you know, took the step to say, so many male economists have had their say, I will now appoint a council of women only. And this indeed has been a breakthrough, and you can clap for him. And so this, of course, also has put the spotlight on many of the issues that have so far been neglected. So it is my great pleasure to give you the floor, Director General.
Thank you, Ilona, and thank you also for accepting the invitation to moderate this. And you're one of the central and important members of the Council. And this was also from the start your idea, so thank you so much indeed. And I fully agree. By design, we said we need to have all women council members. And the surprising part was we were asked the same question, me and Mariana. Why all women? Then we didn't say much. We said, why not? And that's it. Because that question doesn't need a long answer, because we know councils or board with all 10 men or all 20 men. So there is no question when that happens. And when all are women, why would even a question be raised? So that's why we say, why not? Honorable Minister Dr. Akmal Al-Anzarova, Rahmet for joining us. Professor Mariana Mazzucato, Secretary General Martin Chungong, EIB Vice President Thomas Osros, AMREF CEO Dr. Gitinji Gitahi, dear colleagues and friends. An estimated 4.5 billion people lack access to the essential health services they need, and 2 billion face financial hardship due to health costs. Multiple crises, from disasters to conflict to the climate emergency, only make things worse, especially for the most vulnerable. All this is occurring in the context of a global macroeconomic downturn. At last year's World Health Assembly, the WHO Council on the Economics of Health for All, chaired by Professor Mariana Mazzucato, published its final report setting out a bold new vision for health for all as a public policy objective. The Council proposed concrete, evidence-based recommendations on how to rethink, reframe, and restructure economies to deliver healthier populations. And I commend the report to you. I think you can show them again. As I have said many times, investments in health and in UHC should not be seen as a cost, but as an investment in healthy, productive, and resilient societies. Fundamentally, UHC is a political choice, but it's a choice that must be translated into budgetary action. At the UN General Assembly last year, world leaders committed to investing in primary health care as the foundation of universal health coverage. They also committed to investing in health promotion and disease prevention, education and training, and the health and care workforce. Since 2000, 30% of member states have made progress in expanding both service coverage and financial protection towards UHC. Many more countries have introduced legislation, reforms, and increased investments towards universal health coverage over the past year, including Egypt, Indonesia, Kenya, South Africa, and Tanzania. WHO and our partners are supporting countries on the road to UHC by developing national health investment plans. Of course, investment plans must be supported with investments. That's why last year, WHO joined a coalition of multilateral development banks to establish the Health Impact Investment Platform, which marries WHO's technical expertise with the financial muscle of development banks to design and deliver health projects aligned with country priorities. European Investment Bank was the lead, and that's why we're joined by Thomas, the Vice President, today. We aim to start making disbursements from September. It's vital that all international funding is better aligned with national plans, priorities, and systems, as recommended in the Lusaka Agenda. I look forward to hearing your experience and comments as we work together to finance a healthier world for all. And finally, a special thanks to Finland, because Finland has been the patron since the establishment of this council, and for all the support throughout. And we just met with the minister, and Kitos from my heart with deep gratitude and respect. And also for the op-ed that we published with His Excellency, the Prime Minister of Finland, recently. And I think a publication in Lancet will also follow soon. But to Finland, thank you so much for your leadership on this very, very important work, and look forward to working with you to implement it. So thank you so much, and Ilona, back to you.
Thank you very much, Director General, and thank you also for highlighting that this is not just an issue between health ministers and finance ministers. It is an issue of decisions of political will at the whole of government, and of course involvement of prime ministers and presidents to move such a comprehensive agenda forward. As you heard, with the work of this council, what we tried to do was to establish a new narrative on the economics of health for all. And it is my great pleasure to ask Mariana Mazzucato, who of course was the chair of this council and under whose leadership we were able to move forward, to speak to you and explain to you what exactly this narrative is and why it is different. Mariana, over to you, please.
Thank you. Thank you so much, Ilona, as one of my fellow council members, and to Dr. Tedros, our brother, our father, our friend. We usually start speaking in Italian. We will spare you, even though his Italian is not improving. It's the only thing that's not improving in the WHO. And thank you to all the audience here listening to us. So 1 year ago, we launched the report. 10 women represented from all over the world met every month for 2 years. We began with COVID. In fact, one of our members from Botswana actually died of COVID in the first months. So it was tragic, traumatic from day one. But, you know, for the world, realizing just how unprepared everyone was, should have been a wake-up call. And the trillions flooding the world today with industrial strategy that has come back, we would have hoped would have been invested in making sure that global health systems are stronger now. So in the new pandemic, if there's another pandemic coming our way, will catch us more prepared, not less prepared. And I hate to say it, that has not happened. In fact, all the problems that we woke up to, whether it was the lack of personal protection equipment, because industrial capacity in many countries has withered away, whether it was the digital divide, the vaccine rollout, what Dr. Tedros called vaccine apartheid, because the mission was not 8 vaccines, it was global vaccination, and we failed to do that. Again, what have we learned? What are the lessons that we have learned? And this is really what the Council set out to do, to make sure that we actually are learning from these interlinked crises, climate, biodiversity, health. How do we not only do the obvious, which unfortunately is not obvious, but to say health is an investment, it's not a cost, and needs long-run funding, but even do something much more radical, which is to say, if health for all is the goal, what does it mean for the economy? What does it mean for how we value? What does it mean for finance? Not the financial gap as though there's a hole to fill up with money, but the structure of finance. What does it mean for innovation? It's easy to talk about innovation as though it's always a, some sort of friendly partnership, but actually there's different ways to partner. How do we partner in a symbiotic way with the common good at the center of the design of partnerships? And lastly, what does it mean for public sector capacity? So in my limited time, I want to say something about that, but just to make sure that we also don't forget the obvious that I said should be obvious on the dashboard everywhere. The cost of inaction is so much greater than the cost of action. We know this with climate change, right? Nick Stern, who ran that big climate review, he began with that, and it sort of woke up the world. The financial market started to talk about that because of the risk associated with climate change. We haven't made that point strong enough with health, and hopefully this meeting and this resolution, which is so important, could be something like that COP15 was in Paris when the world sort of woke up. Of course, it hasn't. The IPCC report keeps telling us we're literally facing the tipping point. But, an estimated 14 million people died due to COVID, and the global economy lost about $13.8 trillion US. But the cost, if you actually look at the numbers, the World Bank and the World Health Organization say that it would cost a mere $1.30 per person on the planet to build an effective global system of pandemic prevention. Right? And by not doing that, the costs then, again, are in the trillions. And the benefits are huge. If you just look at the non-communicable diseases situation, one estimate suggests that the cost of $140 billion, which are required to reduce by 1/3 global deaths from NCDs, would generate economic benefits of almost 20 times greater, so $2.7 trillion. But these numbers, we can talk the numbers as much as we want, but if we then don't implement on the proactive side, on the positive side, the policies that will truly prepare us to live with health and well-being at the center of our economies, then this is all blah, blah, blah and talk. And what's so important in this room, I think, is that health ministers kind of rise up to the occasion and put health and well-being and the points that we make in this report at the center, not at the periphery of how we think about the economy, at the center of how we think about finance. So the finance ministers should become a bit more humble and let you all really talk about the what. It's the same thing again with climate. Is climate change just for the Minister of the Environment? Of course not. You need that multi-government approach, cross-ministerial approach. Is health and well-being just for ministers of health? Of course not. Right? We were just talking about Sweden. Sweden has a really interesting school meal policy. Lunch, of course, is critical to health. And in Sweden, school meals have to be healthy, tasty, and sustainable. So they use outcomes-oriented procurement to procure that in. Right? So that means actually, what does it mean for Department of Education, a Department of Finance, Department of Environment to put health and well-being at the center? And our 13 recommendations, I think we've We've spread the report out to as many of you as we can, but it's free online. Go across these 4 pillars that I talked about. And we already heard from Ilona, but it's really important to say again, women and feminist economists have been saying some of these points for a very long time. That first pillar on value. How do we value both ex ante and ex post health and well-being? Well, surely not with GDP. GDP, if you marry your babysitter, GDP will go down. So don't do it. Right? If someone was being paid to do work in your house and all of a sudden they're still in the house but not getting paid, GDP goes down. It's just an example, a silly example, I admit it, of how we don't value care, right? By the way, if you pollute, GDP goes up. Why? Because you have to pay for someone to pick it up. So you can see already this dysfunctional measure when we confuse price with value. But what we say in the report is we need a dashboard. It's not just about replacing one number with another number, so it's going to be better. In a car, if you're driving your automobile and there's one number, you will crash that car. So why do we think we can drive our economies with one number, whether it's good or a bit good or a bit bad? We need a dashboard, and that's what this report provides. And I just met this morning with the Minister of Health for Australia, Minister Mark Butler, where they are, in fact, trying to create some sort of a dashboard for the economy under the heading of measuring what matters. Second, finance, and so happy that the EIB is here. To be honest, there isn't a financing gap. There is just money that is not moving towards the right things. There's plenty of money out there. Just the public banks, the national development banks, not the multilateral development banks like the EIB. The national ones together have $22.2 trillion. The MDBs, of which the EIB is one, $2.2 trillion. What would it look like if health and well-being was at the center of missions where the lending was actually conditional on private sector companies working together, collaborating to actually deliver on those goals? And conditionality, by the way, is very important, coming back to the issue of how do we partner in a symbiotic, mutualistic way, sharing risks, sharing rewards. And that second point that I made about innovation, one of our other pillars, makes that really critically in the report. How do we put collective intelligence, collaboration at the center of how we design public-private partnerships? And it's very interesting what's happening in Brazil with the health economy industrial complex, which is very much putting that idea of learning the lessons of what works and what doesn't when pharmaceutical companies, biotech companies, health ministries work together with the common good and health goals at the center. Finance, I mentioned. Innovation, I mentioned. Last one, capacity. Without public sector capacity to implement these policies, nothing will happen. We need to insource that capacity back into our administrative governments at the local, at the regional, at the national level. And the resolution makes the point, again, the need for that cross-ministerial thinking. But of course, one of the big realizations with COVID, but also with all our health problems, is we need to surely get the intellectual property rights, but that's not enough. If we don't have industrial capacity, then we will continue to rely on one part of the world, having to send over medicines and vaccines to another part. What we need is for the whole world to be able to build, to manufacture, and surely then how we share the knowledge along the way matters to build that learning. But the problem is that when we have lots of rent seeking along the way, but also lack of solidarity, but also deindustrialization in many countries, and that's why we need to put also pressure on countries themselves to bring industrial policies with health objectives back at the center. These are all points that we make in the report, and we really hope that with the resolution, it can actually then land across the world, and we're there to help make that happen. So please count on us. The 10 women who put this together will work with you for the years to come. Thank you.
Thank you very much, Mariana. And as you noticed, of course, this can only be a spotlight of the wealth of issues that have been taken up in the report. And also, as we've heard, so such a large group of countries is already going down this road, is doing bits and pieces of it, and it will be fantastic if following the resolution we can bring together all that knowledge, all that activity, and show from the side of health and WHO how this narrative is turned into action. So it is my great pleasure now to give the floor to Dr. Akmaral Al-Nazarova. She is the Minister of Healthcare of Kazakhstan. She has come here specially for these discussions because, as you will know, there is a difficult situation in Kazakhstan, also climate, floods, things that nearly every country is experiencing right now. I would also like to tell you that the Minister will speak in Russian, and therefore to please put on your headphones. Thank you very much, Minister. The floor is yours. Welcome.
Thank you. Уважаемые
colleagues, Director General, Dr. Ghebreyesus, Presidium, thank you for giving me the floor. On behalf of Kazakhstan, I would like to welcome you here and thank you for the opportunity to speak during the 77th session of the World Health Assembly. Allow me to thank the Director General for the initiative and providing Member States with a platform for discussion through this important strategic roundtable. I think we will hear some very important beginnings and be able to share what we have learned. I have the honor today to consider the best approach to achieving universal health coverage, and in particular funding primary health care as an important priority, which really will allow us to leave no one behind. The importance of PHC was recognized by member states of WHO back in 1978, when a historic document for global healthcare was adopted, the Alma-Ata Declaration on PHC. It laid the foundation for states and governments' commitment to ensure that populations have accessible, physically and financially, access to high-quality medical care, and became a precursor to SDG number 3. 40 years later, countries reaffirmed the obligations and commitments they had taken upon themselves in adopting the Declaration of Alma-Ata and adopted the Astana Declaration on PHC, which became a cornerstone for resilient healthcare systems, which is absolutely essential to achieving UHC and the related SDG. Where are we now? All countries are currently facing problems with a lack of funding in the area of healthcare. As we've heard today, global progress in achieving UHC was seriously decreased as a result of the COVID-19 pandemic. And statistics on the scope and protection from financial risks are impressive, and we can see what kind of influence they have on life expectancy and so on the COVID pandemic had. Furthermore, emergency situations as a result of natural disasters and conflict are taking place in many countries and continue to test the resilience of healthcare systems in the face of serious gaps in funding. Kazakhstan, like many other countries, has recently experienced an emergency situation which was the result of significant flooding, worse than we've seen in the past 80 years. A large part of the country was affected, and the government has taken an important role in overcoming these issues, and one of these steps they took was reorienting the healthcare system towards primary healthcare, and the healthcare system demonstrated its adaptability and resilience. We have not seen any outbreaks of infectious diseases, and the organization of PHC, emergency services, hospitals have ensured uninterrupted access to medical care. Medical centers in evacuation areas and centers provided medical treatment. We ensured that medication was available to all patients with chronic illness. We provided psychological aid, and the epidemiological services continue to monitor water sources to prevent any outbreaks of infectious disease. Based on our experience, we want to share recommendations of WHO to reorient healthcare systems towards PHC in order to achieve universal health coverage, because PHC can provide around 90% of basic medical services and ensure continuous access in emergency situations of different kinds. I will call on governments to aim to reorient healthcare systems towards PHC and to implement this in national plans and strategies, as well as placing significant importance on the priority of funding PHC, and that ministries of health and finance should work closely together. Kazakhstan considers PHC-oriented financing of healthcare as a long-term investment to ensure the health and well-being of the population. An important political situation is spending 5% of GDP on healthcare to reduce out-of-pocket payments from the population, and this is a very important factor for us. Funding of PHC and community healthcare should make up to 60% of general financing of the sector. On the 23rd of October 2023, at the Global Conference on PHC, to celebrate the 45th anniversary of the adoption of the Alma-Ata Declaration and the 5-year anniversary of the Declaration of Astana, the President of the Republic of Kazakhstan, Kassym-Jomart Kemaleevich Tokayev, presented an initiative for the creation of a global coalition of countries on PHC and called on all countries to join this coalition. I would like to thank the Director General, Dr. Tedros Ghebreyesus, and representatives of member states for their support for Kazakhstan's initiative. At the WHA, we presented this coalition and our concept for developing PHCs. This coalition aims for a global reorientation of healthcare systems towards PHC, in line with the operational framework of WHO and UNICEF on PHC, which considers financing as a key strategic lever. Joining our efforts within the coalition, we can share our experience, take part in international events, provide political impetus, as well as finding solutions together for problems of gaps in funding. Dear colleagues, allow me, on behalf of Kazakhstan, to invite member states of WHO to join the coalition of countries on PHC and unite our efforts for the fundamental reorientation of the healthcare system towards PHC with the aim of ensuring health and well-being for all in response to current global challenges. Thank you very much for your attention.
Thank you very much, Minister. Thank you for highlighting the role of primary healthcare, the role of communities, and the role of participation, and drawing attention again to the Alma-Ata Declaration. That truly was a document that established a new narrative, a historic document, and those of you that have read it will remember it also related itself to a new way of economic thinking, a new economic order. And I think here we do have a background that many of us could go back to. And I would just encourage you, once you've read this fantastic document, to also go back and read the Alma-Ata Declaration. It is actually a revelation if we do this. So it is my really great pleasure now to move from the executive branch of government to the legislative branch. We often say, you know, political will, and then we talk of ministers and we talk of prime ministers, but we don't talk of the bodies, in a sense, that frequently decide on many of these things, that give it direction, and that, of course, are the parliaments. And that also applies to any pandemic accord we might have. It has to be ratified by parliaments. And so we are absolutely delighted to have this branch represented here through the Interparliamentary Union and its Secretary General, Martin Chungong. Please, over to you, Martin.
Thank you. Thank you very much, Ilona. Thank you for giving me the floor. And let me thank my brother, the Director General of WHO, for giving me this opportunity to talk to you about parliaments and access to health. I have heard a lot of things said, and I'm reminded of the overarching theme of the World Health Assembly this year, all for health and health for all. And we have heard a lot about the challenges that are ahead of us in terms of achieving the noble goal of universal health coverage. I just want to make a case for the institution that in every country is supposed to be the mirror of society, is supposed to be representative of society as a whole, and that is Parliament. I don't think, and this is not being pretentious, I don't think there's any institution in any country that is more representative than parliaments. They are elected by the people, and they are supposed to represent and articulate the aspirations of the people. And I therefore think that it is important, as you said, Eleonora, that we engage with these political institutions to forge the political will that is required to elevate universal health coverage and access to health in general to a priority, number one priority. If this is not happening, then nothing else will follow. The ministers, the other members of government are going to take their cue from Parliament where there is the political will. So I think that parliaments are well placed to achieve that goal of leaving no one behind as articulated in the SDGs. Now, coming to the specific role of parliaments, you've mentioned the one about forging political will. Dr. Tedros talked about legislation being put in place to facilitate universal health coverage in many countries around the world. That is a role that falls to parliaments, building legislation. But coming to what we are dealing with today, in every constitutional dispensation, it is parliaments that hold the purse strings. They are the people who decide on budgets. They allocate resources to the various sectors of the country. And I think that it is important to engage them to make sure that health, access to health, universal health coverage can be a priority and that resources go to this. As Dr. Tedros repeated this morning, it's investing in health is not just a dead-end investment. It's something that is very important to the well-being of people and the economy as a whole. And so, first of all, we talk about equitable distribution of resources, but also to invest, you need revenue. And parliaments have a role to play in mobilizing additional domestic revenue for funding the health sector. And we're thinking of revising the fiscal architecture in countries, the policy framework for tax collection. We're looking at innovative sources of raising revenue, including what we have been engaged with WHO on, the issue of health taxes, raising health taxes for funding the health situation. I say all of this because I sit in Geneva here and I assume that everything is fine out in the field, but no, not so. There are many countries where parliaments are doing well, where they are actually taking the lead in promoting health, but there are many others where parliaments are suffering. They are not able to do this because they lack the resources, they lack the capacity. And that's why what Mariana said earlier in her presentation was very appealing to me. I think it's important for parliaments also to have the capacity to deal with the issue of health, the expert capacity, the technical knowledge, and that's what informs our cooperation with WHO, making sure that we bring expertise to the policymakers so that they can come up with better outcomes, in this case, in health. We also want to stress the importance of transparency. Transparency is very important when it comes to public expenditure, public monies. We need to make sure that parliaments operate in a context of transparency where there is information that is flowing from the governments to allow parliament to track expenditure on operations in the area of health, and then on that basis provide the resources that are required for health. It is also very important for fighting corruption, because in many countries a lot of the resources are lost to corrupt practices, and it is important that there is openness, there is transparency in public operations. I know you fidgeting, Eleonora, because I promised not to speak for more than 4 minutes, but I just want to make one last point. As representatives of the people, parliaments are well placed and are advised to be in tune with the population. And that is why it is important for them to come up with good policy outcomes, to reach out, to engage with the public, to gauge their mood, to gauge their interests and aspirations, and convey this and translate this into public policy and other actions for implementation. And I just want to say that we look forward to continuing our cooperation with WHO because we share the common vision of leaving no one behind. We have the common vision of promoting universal health coverage, and it is important that the two communities, the scientific and expert community in WHO and the policy-making community in the IPU through parliaments can work hand in hand for better outcomes. Thank you very much.
Thank you very much, Martin. Thank you also for raising the issue of transparency and also the need for parliamentarians, for parliaments to be open for debates and discussions. And in a situation, as we all know, where during the COVID pandemic so much trust has been lost, where so much polarization has come into place, those words from your side are indeed incredibly important to move forward. We now move to other partners, and Dr. Tedros had already made reference to the important role of the multilateral development banks. They are becoming more and more involved in health. They are becoming more and more of a partner also to the World Health Organization. And I will pass the floor to Mr. Thomas Östrom, who is the Vice President of the European Investment Bank. Please, Thomas.
Thanks a lot, and it is a true pleasure to be here, Ministers, Excellencies. So the European Investment Bank is the bank of the 27 European member states. We are very much active inside the European Union, but have been active since the start of the bank in the early 60s outside the European Union. Outside, we work on the heading of EIB Global, but our fundamental starting point is that we are the climate bank. I would safely say that we are the most advanced bank when it comes to climate investments. We already in 2019 sorted out all investments in coal, oil and gas-based energy production to go fully into renewables and to interconnections and to see to that it is sustainable for the future. But we're also very much a health bank, and we see a very strong connection between these two very strong guiding poles for us. We saw very clearly how vulnerable health systems are very badly hit by the severe weather events or climate events. We saw during the pandemic that the weaknesses in primary health care is really obvious, not only in many low and middle income countries, but also in some of the more advanced countries. Mariana said something that I think is very important. The cost of inaction is so much larger than the cost of action. And I think this is key for a multilateral development bank, to be able to assess risks and impact of projects, but also to be able to take risk, because without that ability, very little will be done. We try to do that very broadly. I mean, we are now lending and investing in a new, totally green field, green steel factory in Sweden, which, if it is successful, which we hope, will reduce the emissions from steel production by 95%. On the other hand, we also have what we call venture debt, high-risk lending to small and medium-sized companies in the field of health and life science, which, if they are successful, can help us to combat some of the most severe diseases that we encompass. A good example was BioNTech, a small German biotech company. We were financing their cancer research on the mRNA platform. When COVID hit, they knocked on our doors and asked, could we have some additional financing to try to create a vaccine against COVID? And they were one of the first companies to be able to do that. And just a couple of months ago, they inaugurated their vaccine facility in Rwanda. So what we do inside and outside Europe is, for us, very highly interconnected. When we created EIB Global, one of our biggest ideas was to try to cooperate and be a better partner. And I think here WHO has played a very important role for us. Last year, at the end of last year, we devoted 500 million euros to support WHO and UNICEF in the global polio eradication program, together with the European Commission, together with the Gates Foundation also, of course. We also have a Human Development Accelerator program together with the Gates Foundation and the Commission, where we aim to support local pharmaceutical production, vaccine production, but also measures to increase safety and security in the field of health. And we created, as Dr. Tedros mentioned, a joint platform, the Health Impact Investment Platform, that I hope we can be able to sign late June this year, where a number of multilateral development banks go together to coordinate an approach to invest in primary healthcare in low and middle-income countries. So the African Development Bank, the Islamic Development Bank, the Inter-American Development Bank, and just the other day, the Asian Development Bank signed the cooperation. So I think this is the way forward to get real impact, to cooperate more closely with expert institutions like the WHO, but also the community of the multilateral development banks to see to that we get real impact. And Dr. Tedros, I'm very grateful for that cooperation that we've been able to implement in recent years. Thank you very much.
Thank you very much, Thomas. And you can just see it in flashing lights. The European Investment Bank, the health bank. I like that. Maybe we should have a few more of those. Gitinji, if you bear with me, I'm going to ask you to just wait for 1 minute until you speak, because our Japanese colleagues, who have a very important announcement, have asked for the floor, and our speaker from Japan does have to leave because he is co-chair of Committee B. I hope you will agree to that, Gitinji. And I would like to call on Dr. Masima Sakoi, the Vice Minister for Health and Chief Medical and Global Health Officer from Japan. Please take the floor.
Thank you, Iona, and I thank for giving me the floor. Today, taking this opportunity at the strategic roundtable atmosphere, I'd like to explain the details of new UHC knowledge hub that will be established in Japan. In this regard, the government of Japan will support WHO to establish a new WHO office in Tokyo area in year 2025. The strategic objectives of the hub, which would be taken forward with WHO and the World Bank, include: number one, to strengthen health financing, for example, securing adequate fiscal space through domestic resource mobilization and relevant policies of low and middle income countries. And number two, to enhance finance and health coordination to achieve UHC. And number three, to promote knowledge creation and sharing on relevant new issues in this regard, leveraging knowledge and experience of the member states, including Japan. We are pleased that this WHO and World Bank collaboration will utilize the existing global UHC data, information, and analytical work of each organization, and generate additional data and evidence by leveraging the strengths of each organization. They will also offer support for policy discussion and capacity building with policymakers, practitioners from both health ministries and finance ministries in low and middle income countries, including expert peer-to-peer exchange and a sustained engagement approach. The government of Japan will also support the activity of WHO and the World Bank in Japan, including through providing insights from Japan's UHC-related experiences, and welcome other countries to participate in this regard. In addition, in collaboration with WHO and the World Bank, the government of Japan would like to convene UHC high-level forum in Japan periodically, inviting representatives from low and middle-income countries, international organizations, and non-state actors, including private sectors. We believe that this forum will continue to further promoting momentum on universal health coverage globally, and especially increasing collaboration between finance and health decision makers, including building on the activities of the WHO or UHC Knowledge Hub. Thank you very much.
Thank you very much, Dr. Sarkoy. Thank you for this really important announcement. And I think it actually fits beautifully with the points that Dr. Gitinji Gitahi, the Chief Executive Officer from Amref Health Africa, is going to touch upon. What about country ownership here? What is it that we need to take this agenda forward at the country level? So over to you, Gitinji, please.
Thank you. Thank you very much, Ilona, and that was a worthwhile wait for the announcement. Working with ministers of health in Africa, I have realized that financing of health is an extreme sport. And this is so because I know this is a global agenda, but for low and low-middle income countries that have only $100 of total expenditure, compare that with thousands, $6,000, $5,000 in countries in Europe, $10,000 in the US. Ministers of health in low-income countries, especially in Africa, have $100 in total to work with. And that $100 is stacked in the following way. One, of course, is domestic taxes, which is the public, the exchequer contribution. In my country, that is about $40 from the exchequer. Then there is out-of-pocket expenditure, which is by percentage, the low-income countries contribute out of household income, the highest of GDP across the world. So they are the ones who are actually taxed more for out-of-pocket. And then there is development assistance, which will account, depending on the country, to about 20% of that $100, 30 to 20%. So you have little money stacked in three ways. And I think the conversation that we are being asked to have here is, especially where development assistance is part of health financing, is the question of efficiency, effectiveness, and integration. And the question around the fact that because there is such little money, there's no money to throw at the problem. So integrating with national plans, with a national strategy, with national measurement frameworks is a best buy for health. And this is where the Lusaka agenda or the future of global health initiatives comes in. And this is not new. We all remember the aid effectiveness principles of Paris Agreement. We remember the Global Action Plan for SDG 3. I'm not sure we moved a lot on this, not because there was no will, not because there was no desire, but because we have not provided a proper framework for this, which is why the initiative of Lusaka Agenda, which is a child of the future of global health initiatives, which was led by Kenya and Norway, comes in. And this Lusaka agenda, as a result of the work done by Kenya and Norway, was launched in Lusaka last year and then adopted by the Africa Union, not on behalf of Africa, but on behalf of global health, was adopted with certain principles. And principles are as follows. One, we need to strengthen systems for primary health care, because when we have strong primary health care, then everyone wins. The global health initiatives win, the countries win. Secondly, that we need to catalyze sustainable domestic financing. And third, that equity must be at the center. And four, there has to be strategic and operational coherence at country level, coordinating products, research, local manufacturing, and all this encapsulated in a national one plan, one budget, one report with respectful partnerships. We must reinforce that this agenda is not either saying we don't want vertical, we want horizontal, or horizontal instead of vertical. It is a diagonal agenda. It's actually about doing what we're doing, saving lives as we are, but ensuring at the same time we're building sustainable primary care systems for the future. So what next? Where are we? The ownership of this Lusaka agenda is important because what you've seen with the previous initiatives is they fizzle away. There's no accountability, there's no governance frameworks. So the Africa Union passed a resolution at the heads of state level in February to support this agenda. Again, I insist, for the world, not for Africa. And just taking leadership so that we can all align. But I think for me and for us, for this agenda to succeed, it must be embedded in national leadership, that unless the national ministers of health, ministers of planning, ministries of finance lead the way for accountability, transparency, and national plans, is going to be difficult to implement the Lusaka agenda. For WHO, our call is for WHO to integrate this approach to its technical leadership and technical support to countries so that it is not left hanging at national level. And this then enables the three-stack concept I talked about, or domestic, again, pooling domestic resources and ensuring that domestic assistance is aligned to the national plan. And that concept then delivers music for all of us. And that music is good health and well-being for all in the countries. Thank you, Ilona.
Thank you very much, Gitinji. And you see we have a number of guidebooks in a way, the historical one of Alma-Ata, the new one of the Council and the Lusaka Initiative and everything that flows from it and the way it has been adopted politically. Dr. Tedros already made reference to the important role that Finland has played for this agenda in support of WHO, both at the global and at the regional level. And it's my great pleasure to call on Her Excellency Sanni Grahn-Laasonen, the Minister of Social Security of Finland, who I believe will also make reference to the resolution that is awaiting the discussion here at the World Health Assembly. Please, Minister.
Thank you very much, Excellencies and participants. On behalf of Finland, I would like to extend our gratitude to Dr. Tedros for his leadership in introducing the topic of economics and health for all on the WHO agenda. We would also like to thank the members of the Council for their work in conceptualizing this theme. The Council stressed the need for building the necessary capacities of governments and societies to deliver health for all. Finland, together with the group of member states, has proposed a resolution in this Health Assembly, as mentioned, with the aim of mandating the Secretariat to develop, in consultation with member states, a strategy on how to implement an economics of health for all approach, including priority actions for member states and other actors. We recognize that we need better mechanisms for dialogue between different administrative sectors. The economy of well-being approach can serve as a good model for cross-sectoral collaboration. It's based on sound economic policies. It emphasizes that effective and efficient policy measures on gender equality, health promotion and disease prevention, social protection, education and occupational health and safety can have important macroeconomic and microeconomic impact. It's important to increase understanding of the mutually reinforcing linkages between health, well-being and the economy through data on economic returns. To conclude, I would like to share greetings from Finland's Prime Minister Petteri Orpo and end by quoting him and Director General Tedros from their joint WHO bulletin editorial. We need new models to help us reimagine the future. Let us together deliver on this. The UN Social Summit in 2025, next year, will be a great opportunity for us to boost the achievement of the universal health coverage and the goals of the Agenda 2030, including through the economy of well-being approach. So thank you very much.
Thank you very much, Your Excellency, and thank you again for the consistency of the Finnish support to this agenda. We now have the opportunity to hear a number of voices from the floor. My plea to each and every one of you is please no more than 2 minutes, then everyone will get their voice in and we can end punctually, and the moderator will sacrifice her summary remarks. I would like to call on Canada, on Joseph Jenkinson, Global Health and Development Advisor from the Permanent Mission of Canada here in Geneva. Please, Mr. Jenkinson.
Thank you very much, Thank you very much, Ilona, and thank you all for this session today. Greetings, esteemed colleagues, members of the health community. Canada shares the view that health is an investment, not an expenditure. But ODA budgets and domestic financing are under pressure. Where we can't count on more funding for health, we must ensure more effective and impactful spending. Country ownership has always been a key principle of development cooperation, but in practice we know that external financing for health, while helping to achieve significant health wins, can displace rather than incentivize domestic financing. And we need to shift our thinking to support community-centred health systems in a more efficient, effective and sustainable manner. And building on the comments from Dr. Gitinji, Canada is pleased to be a co-chair of the Lusaka Agenda Working Group alongside Ghana and AMREF. The working group has been focused on ensuring the Lusaka conclusions on the agenda, ensuring the Lusaka conclusions are on the agendas of the governing boards of the Global Fund, Gavi, the Global Financing Facility, in addition to the African Union, as has been mentioned. But country voices, in particular those from the African region, have been the vital driving force of this process, and the active role of civil society and communities is also absolutely critical, and this collective effort must continue. Finally, just to say, it was excellent to hear such resounding support for WHO's new General Programme of Work in Committee A earlier this week. GPW 14 is strongly aligned with the Lusaka Agenda, and this stands WHO in great stead to help drive the Lusaka Agenda forward at the centre of the global health architecture. Canada looks forward to continuing to work with all of you in advancing this important work, and thank you very much for this very great discussion and a very timely session today. Thanks.
Thank you very much, Canada. It's my pleasure now to call on Dr. Virosh, Global Health Advisor to the Permanent Secretary Office of Thailand.
I have 5 policy messages. First, increase ODA, increase allocation of DAH, and allocation to primary health care, and public health function and preparedness for another pandemic. This is in line with Lusaka Agenda. Second, increase public and ODA investment in PSC as a foundation for implementing USC with successful outcome. And American economist Professor Gruber said, Thailand USC is a great equalizer. It nullifies IMR across rich and poor countries. Third, rich and poor provinces. Third, extend Lusaka Agenda to cover bilateral DH, multilateral and bilateral loans, not focus only GHI. I have read carefully. Lusaka Agenda only focus in GHI. Fourth, promote transfer technology and know-how, and increase manufacturing capacity in LMIC. This is one of the most contentious issues in the INB pandemic agreement negotiation. It's not easy. It's easy to write in the Lusaka Agenda. It's not easy to translate into reality. Finally, Lusaka Agenda may follow the path of not successful Paris Declaration on its effectiveness. And the last report is 2008. No update report on what happened in Paris Declaration on its effectiveness. Unless one, donor and country have good faith to succeed and the mechanism to monitor progress is well in place. Thank you, Ilona.
Thank you very much, Virosh. We have 10 more minutes and 5 speakers, so this is a challenge, and I hope you will face it with me. So I would like to call on Indonesia and Ms. Linda Wartani from the Ministry of Foreign Affairs, please.
Thank you so much, Professor Ilona. Thank you very much, Director General of the WHO, Mr. Tedros Adhanom Ghebreyesus, for convening this important strategic roundtable. Ministers, Excellencies, distinguished speakers, ladies and gentlemen, as emphasized in this strategic roundtable, Indonesia shares the view that urgent investments in health with a strong focus on reorienting health systems towards a primary healthcare approach represents a key global priority to achieve universal health coverage. The political declaration of the high-level meeting on universal health coverage adopted in 2019 and 2023 stressed the need for scaling up efforts to prioritize health promotion and disease prevention. The implementation of Lusaka Agenda, conclusions of the Future of Global Health Initiatives process would be supportive to a global and national health priorities towards achieving the universal health coverage. Learning important lessons from the COVID-19 pandemic, Indonesia has developed health transformation, focusing on primary care transformation, referral services transformation, health resilience system transformation, transformation of the health financing system, transformation of health human resources, and health technology transformation. And in the pursuit of universal health coverage, Indonesia stands committed, among others, in providing national health insurance program to ensure equitable access to healthcare for all, and then allocating state funds in healthcare across the country, engaging with international organizations, NGOs, and private sector to enhance its capacity for innovation and investment in healthcare, and conducting public-private partnerships as an innovative approach in financing and implementing healthcare projects. Let us work together to ensure health equity and achieve universal health coverage by 2030 in line with the Sustainable Development Goals. Thank you, Professor Ilona.
Thank you very much, Indonesia. I'm rushing you through this, and I now call on Brazil, on Carlos Godelha, the Secretary of Science, Technology and Innovation in the Ministry of Health. A challenge to you, Carlos, 2 minutes.
It's not a big challenge, I promise. Dear Dr. Tedros, Mariana, Ilona, and colleagues, congratulations. It's a very, very important work in the perspective for the global health. Brazil has co-sponsored the resolution with Finland and the other countries and was part of the core group. We also had a Brazilian researcher from Oswaldo Cruz Foundation as a council member. As Mariana told us, there is a strong convergent approach in Brazil. The health economic industrial complex is in the top priority of President Lula's development policy to direct the industrial and innovation policy to health needs. More than 20 ministries are coordinated by the health ministry. It's completely new if you think about the industrial and innovation policy. I'd like only to talk to you about an agenda that we need to explore. What are the specificities of the less developing countries to evolve in this approach? I think nowadays that we are discussing the pandemic agreement, it's very important to talk about world asymmetries and how to face that, considering the necessity of developing countries. Again, congratulations.
Thank you so much, Brazil, and thank you also for the commitment you're showing to this agenda in the context of the G20 presidency. We have one more country that I would like to call upon, the Democratic Republic of the Congo, Dr. Serge Emmanuel Holen, Vice Minister de la Santé Publique, Hygiène et Prévention. The floor is yours. 2 minutes, please.
Oui, merci beaucoup, professeur, pour la parole.
Thank you very much for the floor. I just wanted to take the floor to say that our country, the Democratic Republic of the Congo, supports the Lusaka Agenda 100%. Domestically, we have already adopted measures to improve recruitment and resources with innovative financing with a view to increase our budget. For the first time in our country, we've been able to mobilize universal health coverage with free care for mothers and children. We've mobilized 42 million for the first time in the DRC through our own funding, but our partners have also supported us and donated 200 million. This has enabled us to roll out universal health coverage to 13 of our 26 provinces. Furthermore, we're asking all donors to be mobilized to ensure that we can do things domestically, like I said earlier, and to ensure that this is part of our national finance policy. However, it's also important for us to underscore some challenges. First of all, inequality in finance in the DRC. We've seen, for example, that in the provinces of the east of the country, all of the aid allocated to us, all of the donors who come, focus on that part of the country, the east. It would be good if we could have some more equity in the distribution of this support. Thank you.
Thank you very much, DRC. I would like the ladies and gentlemen in the room, if you can bear with us for another, at the very most, 5 minutes. I know that a representative from the World Bank wanted to take the floor. Ms. Monique Fleder, Head of Health, Nutrition and Population Department. Are you still with us? Yes, please, Monique. Please, a very short message, if I may ask you.
Thank you very much for the opportunity, and delighted to have this brief opportunity. In April this year, President Bonga announced a new UHC target of 1.5 billion people reached, and we were delighted Dr. Tedros joined us for that announcement, given the importance of our partnership with WHO for the achievement of this UHC target. We currently have $35 billion in health system financing in over 100 countries, and we're planning to expand that through an increased geographical coverage and footprint of our projects, increase the financing and the scope of services to include non-communicable diseases, and to lower financial access to services as a big predicament for people to be able to access services. We'll do that through 3 approaches. One is by deploying all of our financing tools that we have, including IDA, IBRD financing, as well as collaboration with our private sector arm for those investments in local production and other public-private sector partnership that will enhance UHC outcomes. Partnerships are central. We want to play our role in the alignment agenda on country level, and given the ambition of the agenda, this really needs to go hand in hand with other organizations, and as part of that, we also fully advocate for a well-financed WHO to work in partnership on this agenda. And we are really grateful to the government of Japan for the opportunity they are providing to the World Bank and WHO to collaborate around the UHC hub, which will allow us to work with ministries of health and finance on this ambitious UHC agenda. Thank you very much for the opportunity.
Thank you, Monique, and thank you for the briefness, and of course also for the announcement that you've made. That's very important messages for the countries. The last speaker from the floor now is about the future. It is one of the youth representatives, Arwa Harni. Please, just a very short statement, Arwa, please.
Thank you so much, Your Excellencies and esteemed delegates. Thank you for inviting me to speak. Upon graduation and as we embark on our professional journey, we pledge to serve, protect, and safeguard humans' health and well-being. It's an oath we take as healthcare professionals to always strive for the best care for our patients, non-discriminatory and of high quality. And it's also an oath often hard to fulfill and uphold within today's health systems. Systems that are inequitable, limiting, and unjust. Systems that we need to change. As a practicing doctor, oftentimes I'm not able to provide these essential services due to limited available logistical and financial resources. And oftentimes, I'm limited by my own human capacity as we strive to compensate for the reduced number of available workforce. What does this mean for our patients? It means that some are not able to access life-saving healthcare. It means long waiting lists. It means that some have to resort for out-of-pocket expenditure over the expense of other essential living elements. It means mothers crying for available hospital beds. It means a child is at risk of losing their life to a preventable infection, but there is no accessible healthcare service nearby. While working in health systems has taught one to be resourceful and innovative to deliver the required quality care, in the most limiting settings, it is not a sustainable solution if health is not a front center to every policy. Then what will investments in healthcare mean? It means we uphold our commitments toward providing comprehensive, inclusive, and equitable healthcare coverage for all populations. It means maintaining transparent and efficient public financial management systems and increasing the spending and investments in healthcare to solidify universal health coverage. It means having a robust physical strategy to retain healthcare workers, their satisfaction and continuous contribution to healthcare delivery. It means birthing life to a sustainable and equitable community. Thank you.
Thank you very much, Ava. And as I promised, we will end nearly punctually. And I will ask Dr. Bruce Aylward, the ADG for Universal Health Coverage and Life Course, to close this meeting. Please, Bruce.
Thank you very much, Ilona. Excellencies, delegates, we've had a fantastic hour just over here now, and I'd like to thank all of you for participating, and especially this tremendous panel. I do want to say a word about how timely this discussion has been, because, Ilona, you may not have known in all our panel, but 2 floors up, for the last 2 hours, we had 90 member states talking about universal health coverage. They said, here's how important it is, here's how hard it is, and here's the reason. And it was often financing that was the challenge. And now they're going to go back into that room in the next few minutes, and they're going to try and figure out, okay, how do we take this forward? And I think this has been so timely because, Khadija, you put it so well, dealing with finance ministries is, what did you call it, an extreme sport. Yeah, it's an extreme sport. And I think for any of you who play extreme sports, you have to be bold. And we did promise a bold vision in laying out the title even of this. And I want to thank Mariana for you laying out that bold vision. It's not about the economy, Stu, but it's about health and well-being, I think, is our theme going forward. And it's about delivering what matters. And what matters is health and well-being. Tough to be bold by yourself, of course, and for that reason I want to thank all our other partners who have promised such support in taking this vision forward. To you, Martin, our friends in politics and in parliaments who will be crucial, thank you so much. And to you, Minister Akmaral, for giving us the why. Here's what you get for that investment. And to our bankers, who have said that they are with us, both here and our World Bank colleagues, of course. Thomas, thank you so much for joining us and for that commitment. And I think that message around the cost of inaction and helping us know how to talk about bankers, about funding what matters. So thank you for that. And with that, have I recognized our whole panel? There's one I haven't recognized, and that is, of course, Ilona. And I think our moderator deserves, as a whole panel, a tremendous vote of thanks for keeping us online. Folks, we've talked about everyone else being bold. We can assure you the World Health Organization will be bold as well, taking this agenda forward. We got marching orders from our member states yesterday about our new global strategy for health, which we put together with all the member states, all our friends, and it's all about taking forward the systems and ensuring they're financing, that there's financial protection. And later this week, we expect to get more marching orders about how we create economies for economies that deliver health for all, and our role in doing that. You've asked for our help. We will provide our help. We'll play our role, but let's start by going upstairs and infusing some of the energy and excitement and boldness from this panel into that discussion about how we move UHC forward. So thank you all very much, and a special thanks, of course, to our Director General who put this on the agenda and dedicated one of those very rare strategic round tables to such a crucial agenda. Thank you.